MI and ventricular fibrillation. For complex ventricular tachyarrhythmias, Shomu will be talking further, but the treatment may be antiarrhythmic drugs. Sympatholytic therapy, very important. Beta blockades have to be given to these patients. Sedation, anxiolytics, external cardioversion or defibrillation, transvenous anti-tachy pacing in some patients, ICD implantation in some patients, RF ablation in some patients, revascularization, and ultimate thing is heart transplant for certain other patients. So acute coronary syndrome patients will have polymorphic VT, but those who are beyond the first 48 hours of MI, generally they end up with monomorphic VT, or especially those who are beyond 6 weeks, or like yesterday I said, beyond 40 days. These are late VTVF. Generally these patients may have ventricular tachycardias which are monomorphic, very regular looking wide QRS tachycardia. This is RBBB and inferior axis tachycardia. Now the rates could be different. The patient has VT at a rate of 140 beats per minute here. This is 188 beats per minute, 125 beats per minute. And this is what I said yesterday. At this rate, the patient may be having a blood pressure of 120. But at this rate, the patient's blood pressure may drop to 70. So if a patient who has structural heart disease, post-MI, LV function 25%, gets a VT which is hemodynamically stable, it is still not safe to send the patient home on beta blockers and amio. You would be giving these patients to prevent these arrhythmias, but this point of time patient has a hemodynamically stable VT, but tomorrow the patient can have this type of VT or a even faster VT or a ventricular fibrillation which will kill the patient. So this is just a clue that the patient has a substrate of getting another type of arrhythmia, and it is very important to tell these patients regarding the need of ICD. The monomorphic VT is related to scars in the infarct. So along these are scars, this is surviving normal tissue, and the conduction occurs slowly along these areas, and these set up re-entry circuit. There is potential to identify these circuits and ablate it. So when for monomorphic VT, we treat the patients for heart failure, electrolyte abnormality, exclude ischemia, revascularize the patient, give beta blockade, amiodarone, and catheter ablation if possible. So if we are just able to interrupt the circuit, we may be able to get rid of some of the arrhythmias. This is an example, one patient post CABG, LV function of 30%, monomorphic VT. He was taken in for a EP study. This was a second morphology of ventricular tachycardia that he had. This is an example. See, the cycle length here is 320 milliseconds, about 180 beats per minute. Whereas he had another tachycardia, 220 beats per minute. He may be having multiple morphologies of these VTs. So we localize it looking at the signals, try to find out where it is coming from, and ablate. So this is tachycardia going on, RF energy started, and the tachycardia terminates at this point. Patient is in sinus rhythm. After sinus rhythm, these are the normal intervals of the patient. And since MI is extensive, scars may be multiple, the amount of ablation required may be a lot. Each of this red spot is an ablation spot, and patient has multiple morphologies of ventricular tachycardia. This is one morphology, second, third, fourth, fifth, there may be many more. Often the substrate is changing. As ischemia occurs, as scar extends, the channels may spring up and different types of morphologies of VTs may occur. And the treatment ultimately for these patients is putting in a defibrillator, which will save the patient's life if VT occurs despite your beta blockers and antiarrhythmic drugs. There are certain problems, certain patients who are in ventricular tachycardia, ventricular fibrillation, STORM, where it has been shown that the Purkinje system often throws PVCs and which may initiate ventricular fibrillation, even in absence of structural heart disease. These are called idiopathic ventricular fibrillation. A similar mechanism has been shown in ventricular storm after acute MI. So if the patient is having multiple VT episodes every day, then we may be able to localize the spot from where the PVCs are arising, and we may be able to ablate it and at least reduce the number of ventricular tachycardias that the patient has. Lastly, coming to a type of ventricular tachycardia which occurs in patients with diseased heart, dilated heart, both in coronary artery disease and in dilated cardiomyopathy, that's non-ischemic cardiomyopathy. The LV is dilated, the conduction system is diseased. These patients are prone to getting a peculiar type of ventricular tachycardia. It's called bundle branch reentrant tachycardia. Again, the morphology is a wide QRS tachycardia. LBBB type pattern is the most common and left axis is the most common. I think somebody just talked about it. LBBB and left axis tachycardia, but it is very unlike the RVOTVT, which is LBBB inferior axis, which is in normal patients, and RBBB left axis in idiopathic LV tachycardia, again, which is in normal heart patients. These are patients with diseased hearts, so echo will at once tell you what is the problem underlying. So LBBB left axis is the commonest morphology, and the mechanism is it is in dilated diseased hearts. Substrate may be ischemic or non-ischemic cardiomyopathy. Morphology, as I said, LBBB left axis occurs due to re-entry between the right and left bundle branches in presence of slow conduction due to diseased myocardium. So this is the AV node, right bundle branch, left bundle branch, this is the IV septum, this would be the heart, and due to the slowed conduction, the ventricular arrhythmia occurs in a re-entrant circuit like this. If we are able to identify this, the treatment is very simple. All we need to do is just go in with catheters and ablate the right bundle, and the re-entrant circuit will be interrupted, and the patient will not get this type of arrhythmia again. But remember, these are diseased hearts, so the patient may still get a myocardial VT from the scars. So the patients have to be protected with an ICD anyway. So catheter ablation of right bundle branch. We look at the right bundle potential, ablate it. The patient has developed a RBBB morphology here, but the tachycardia would be terminated with that. Shomu, I am sure, will cover this, but the treatment for all these ischemia related arrhythmias, revascularization, beta blockade, protection by amiodarone, VT ablation in some patients with incessant or frequently recurring VT, overdrive pacing or general anesthesia may be given in patients who have sympathetic overload, and spinal cord modulation. Prognosis always depends on type and stage of underlying heart disease. So the prognosis is excellent for RVOTVT and idiopathic LV tachycardia. Type of arrhythmia, VT or VF, and type of presentations, frequent, clusters, storms, or incessant episodes. So management of patients of VT needs to be individualized. You have to identify the mechanism, identify the substrate, and patients should be referred to an experience center that has all modalities of interventions available where they can be managed with. Thank you.